Hi, everyone. My name is Nina Sanford. I am a GI radiation oncologist at the University of Texas, Southwestern in Dallas, Texas. In the next 25 or 30 minutes or so, I am going to try to give an overview of GI radiation oncology. So let me go ahead and share my screen. All right, this is Rad Onc GI Review, what I think you need to know to pass the oral boards. So first things first, I took the oral boards in May of 2019. At that point, I had a 3-month-old baby. So if I can pass it, anybody can. I don't know why. The day before the test, I decided to hit up one of my favorite stores called the Dollar Tree. And I actually took the last in-person test in Tucson, Arizona. It was actually the first time they were at that site. And then after, because of COVID, they went virtual and they've stayed virtual. And then after is just a drinks I had with my co-residents after the test. We're all pretty relieved it was over. Anyway, so I have one slide per disease site, giving sort of all the high level, I think, high yield information. So we'll start from the top of the GI tract and go down. So let's start with esophagus, GEJ, gastric. So there are really four main indications for radiation. The first is a patient has a resectable esophagus or GEJ adenocarcinoma. We know now that perioperative FLOT is a standard of care based on the ESOPEC trial, but we can consider adding pre-op chemoradiation in select patients if they're not a candidate for FLOT, or if they receive induction FLOT, but based on restaging scans, there's concern for R1 resection. If the histology is squamous cell carcinoma, then the cross regimen with neoadjuvant chemoradiation and then surgery is the standard of care. And then if a patient has an unresectable tumor, then we treat it definitively with chemoradiation. Oh, let me put on my timer. And then lastly, for gastric cancer, you'll notice that the first three were for esophagus and GJ cancers. Parrot FLOT is and has been the standard of care. The cases that we could consider adding radiation is if they have a poor response to induction FLOT, like I said before, and then postoperatively, if they have a positive margin, if they have a poor pathologic response to FLOT, or really extensive lymphadenopathy with an inadequate dissection, a lot of extranodal extension. It really has to be a combination of factors for local recurrence. Things to know about technique. We want to do a 4D CT to assess for motion when you're looking at the lower esophagus or the G junction, the stomach. You want to give IV and PO contrast, and we plan with IMRT. What dose do you use? So pre-op, I think you can say anywhere between 41.4, which is what they use in CROSS, to 50.4 gray. Definitively, we go from 45 to 54 gray. There have been several dose escalation trials for esophagus cancers, and those have all been negative. So we don't really have the data to go above 54 gray into the 60s. The one exception is if it's a cervical squamous cell cancer, then you can consider treating with really a head and neck dosing strategy. Volume. So what do I do personally? We do IMRT with SIB here. So I do 45, 50 gray and 25 fractions SIB. The high dose, I encompass the tumor and then a 1.5 cm mucosal extension. What does that mean? I'm not extending into the lung, into the heart and the bone, but it's really along the mucosa, whether it's up along the esophagus or more distally into the stomach. So that's a high dose. And then the low dose, the tumor plus about a 3.5 centimeter extension. Remember that anything below the carina, you want to cover it to the celiac nodes. Remember the gastrohepatic nodes. Those are the nodal regions kind of in between the stomach and the liver. And then upper esophagus, you want to cover the supraclav nodes. What trials do you need to know? And just to reiterate, on the boards, they're not going to ask you the nitty gritty of the trials, the exact results, the tables, table 1, table 2, the figures, but you need to know generally what the trial showed. So you need to know the cross trial. That was preoperative chemoradiation versus surgery alone, showed a survival benefit with preoperative chemoradiation. That was for esophagus, adenocarcinomas, and squamous cell carcinomas. FLOT 4 compared perioperative FLOT versus ECF, establishing perioperative FLOT as a standard of care. Neo-AGIS compared CROSS versus FLOT, CROSS versus perioperative chemotherapy. Most patients got ECF and actually showed no difference. ESOPEC compared CROSS versus FLOT with all patients receiving FLOT and showed a survival benefit to FLOT, which is now the standard of care. Top Geared compared perioperative chemotherapy with or without preoperative chemoradiation. That was the most recent trial to come out, and it was negative for the addition of preoperative chemoradiation. And then Checkmate 577 was a trial of adjuvant nivolumab for patients who received the cross regimen and did not have a pathologic complete response, and showed that the addition of adjuvant nivolumab prolonged disease-free survival. What other things do you need to know, I think, for this disease site? You got to know the Seward staging, Seward 1, 2, 3. Traditionally, many places treat Seward 1 and 2 as esophagus, Seward 3 more like gastric, but with ESOPEC showing superiority with perioperative flot, that blurred a little bit since now perioperative flot is sort of the standard of care for all Seward GE junction tumors. Adjuvant nivolumab, which I just mentioned, based on Checkmate 577, up to a year. You need to know the cross regimen, that's weekly carbotaxol. Have been trials looking at organ preservation in esophagus cancer. Many exciting trials coming out, but that is not yet a standard of care. Next, pancreas. Okay, so pancreas is interesting because a lot of the studies with regards to radiation have been negative, and there is a wide variation of practice patterns across the country with regard to everything, but including radiation. There are centers that give radiation to almost all patients with localized disease, centers that give radiation to really none. I think as long as what you're saying you can back up, kind of makes sense, then I think you should be good to go. So I would say that the indications for radiation in pancreas cancer and localized pancreas cancer depend on surgical resectability. So if you have a resectable tumor, there's really no standard role for radiation at this time. In fact, the ongoing Alliance trial does not include radiation, but at this point, we consider adding postoperative radiation if there are risk factors for local recurrence, remembering that unfortunately, most patients with pancreas cancer recur if they're going to recur distantly. So distant recurrence is a much greater risk for these patients. But risk factors for local recurrence, obviously positive margin, potentially nodes, plus minus. So RTOG 0848 showed that node negative patients might benefit more. And then LVI, PNI. So it really has to be a patient with multiple risk factors for local recurrence that you might consider adding post-op radiation. For borderline resectable pancreas cancers, the patient gets induction chemotherapy, and then we consider adding preoperative radiation if there is continued vascular involvement. Basically, the patient's at risk for an R1 resection, and what is more concerning is arterial versus venous involvement, since venous involvement can be reconstructable. In the locally advanced setting, again, the patient gets induction chemo, and then you can consider adding definitive radiation for local control. And just to back up, you should know the definitions for resectable, borderline, and locally advanced. The NCCN has criteria basically based on the extent of vascular involvement, arterial versus venous. Just kind of generally, resectable for me means someone looks at the initial imaging, they feel like they can take it out with an R0 resection. Borderline means that one might be able to take it out, but it's probably going to be an R1 resection. And then locally advanced means that it is unresectable. What do you need to know about techniques? So again, just like I said at the beginning for pancreas, practices vary widely, between SBRT versus conventional. Institutions are doing things a little bit different. I would just say what you're doing at your institution, and that is, probably within standard of care. But generally, for SIM, you want to give IV and PO contrast. You want to do 4D CT. For SBRT, you should mention that you would highly recommend fiducials. Metal stents can be used as surrogates, but fiducials are better. You want to do triple phase contrast, and the patient should be NPO. What dosing do you do? So again, this is variable, but what we tend to do, and what I would say if I were taking the boards, is we do 40 gray in 5 fractions to the GTV with a simultaneous low dose volume of 25 gray in 5 fractions. For the elective volume, you can sort of emphasize the at-risk vascular structures, the celiac and the SMA, more so than like a big nodal field with SBRT. In terms of organs at risk, the highest risk structures are the stomach, duodenum, and small bowel. We don't know the right metrics for them, and they probably vary from patient to patient, but what I do is for each, I do V33 gray, less than 0.5 cc's, V30 gray, less than 5 cc's, and sometimes I'll give a 3 millimeter PRV, depending on if we're doing MR guided or adaptive, but I think if you mention all those things, you're probably good with regards to SBRT. For conventional, 50.4 gray and 28 fractions is reasonable. RTOG 0848 has a nice post-operative contouring atlas, and that is given with radiosensitizing chemotherapy. There are, again, a range of regimens that people use, and if you're using these other regimens, I think it's reasonable to say Memorial Sloan Kettering pioneered a more protracted course of dose-escalated radiation using 15 to 25 fractions to 67.5 to 75 gray. They both target a BD of about 100 gray. And then Preopanc trial uses something different, a hypofractionated regimen of 36 gray and 15 fractions. So I think all those are reasonable. Just say what you guys do. MR-guided adaptive, those are new technologies, obviously, in radiation that I think are beneficial in pancreas cancer. You are not going to be, I don't think, tested on the details of those, but you might want to say that these are potentially promising technologies with regards to radiation in pancreas cancers. What are trials to know? Obviously, there are historic trials in pancreas cancer. There is the Gastric trial that people like to cite that is probably has a lot of limitations when we extrapolate to 2025. I think if you know these trials I listed here, probably should be okay. Resectable, recently presented RTOG 0848, resectable pancreas cancer, randomized patients to adjuvant chemorads versus none, showed that for patients who are node negative, there seemed to be a DFS and OS benefit. The hypothesis being that if you're node negative, then you are less likely to recur distantly. You can see Preopanc 1 and Preopanc 2. I included in both resectable and borderline because they included patients from with both resectable and borderline. So Preopanc 1 randomized patients to upfront surgery followed by adjuvant gem versus preoperative radiation and then adjuvant gem, and the radiation was 36 gray and 15 fractions. And it showed a 5-year late OS benefit with the addition of radiation. Obviously, the limitation here was that gemcitabine was a chemotherapy used, so that led to the Preopanc 2 trial, where you took the winning arm of Preopanc 1, pre-op chemoradiation with gemcitabine, and then compared it to FOLFIRINOX, and surprise, surprise, there's actually no difference in between the two. Folks thought definitely the FOLFIRINOX arm would win, but that wasn't the case. You probably should know the Alliance borderline resectable trial. This was a trial that looked at 2 treatment strategies for borderline resectable pancreas cancer, preoperative FOLFIRINOX versus preoperative FOLFIRINOX plus high dose or SBRT. It showed no benefit with the addition of SBRT. There are some limitations in the studies with regards to potential arm imbalance, and also the trial was not meant to compare directly those 2 strategies. That being said, it did not certainly show a benefit to the addition of preoperative radiation for all comers. So that was a negative trial. For locally advanced pancreas cancer, 2 main studies, CONCO 007 and LAP 07. Those looked at the additional of standard conventional dose chemoradiation and showed no OS benefit. And then MR-guided, there are no randomized trials, but the SMART trial was a single-arm trial that showed very promising outcomes. Other things to know, FOLFIRINOX and Gem/Abraxane are the main chemotherapy regimens. In borderline and locally advanced pancreas cancer, always start with chemo. Don't say start with surgery. You've got to always start with chemo. Make sure these patients don't develop distant mets, then consider local treatment options after. We aim for about 6 months of chemotherapy total. More TBD. We have a energy contouring atlas for pancreas cancer. You do not need to know the details of that for the oral boards, but in case you were wondering more about anything I just mentioned, there is nitty-gritty detail in radiation planning and contouring in that. And just also a plug, I don't think you need to know this for the boards, but we do have a trial looking at dose-escalated radiation in locally advanced pancreas cancer that should be opening up this year. It's a cooperative trial. All right, let's take a quick break before we get on to the other disease sites. This is a picture of me next to a cactus, proving that I was in Tucson, and this is literally right after the test with a couple of my co-residents. What else? So you guys don't have to take the tests in a hotel, which is probably good because that could be very awkward. So I don't know if you've heard stories basically of so the way the old test was done, you are in like a long hall, and one by one, you go into the examiner's hotel room, which is like super awkward because if you need to go to the bathroom, you have to like use their bathroom in the hotel room. You're like sitting on their bed taking the test. Probably wouldn't fly in 2025, but that's how we did it for decades. Okay, let's keep going. Rectal cancer. Okay. So indications for radiation in rectal cancer. Basically two. We give it preoperatively to reduce the risk of local recurrence. And what are risk factors for local recurrence? Distal tumors require an APR. If they're less than 1 millimeter or touching the mesorectal fascia, T4 tumor, obviously. If they have lateral pelvic nodes outside the mesorectum, also if there is EMBI. EMBI, however, is a risk factor for local and distant recurrence. Okay, so that's first one. And then the second reason is if you are intending or trying for organ preservation, so avoiding surgery. And in that scenario, you would give long course chemoradiation and FOLFOX and response assessment. That is a regimen with right now the best supporting evidence. Just note that the NCCN actually recommends total neoadjuvant therapy, meaning pre-op chemoradiation, pre-op chemotherapy for all T3 and node positive tumors. So this is really a safe response to say for a lot of different scenarios. I think for rectal cancer, it's also important to know about radiation omission. You may be asked about that because there have been some studies that have come out with looking at when it might be safe to omit radiation. So the first is upfront surgery is an acceptable treatment option per ASTRO, for ESMO, for so-called MR-defined good prognosis tumors. What does that mean? These are low-risk tumors, meaning they're in the upper rectum. They can be up to T3B and 0, no MBI, and obviously not touching the mesorectal fascia. There have been multiple prospective series, not randomized trials, but prospective series showing that the local recurrence risk is less than 5% if they start with surgery. And then second, we'll talk about prospect, but would be patients who are eligible for the prospect trial. These are patients who are LAR candidates who are not T4. You can start with FOLFOX and then go straight to surgery without radiation, presuming they respond to chemotherapy, which will be the majority of patients. In prospect, it was like 91% of patients. What do you need about technique? Short course radiation is 5 times 5. Long course chemoradiation is different ways to do it, but a safe way is 50.4/45 gray in 28 and 25 fractions with radiosensitizing chemotherapy. Given the trend to more organ preservation, long course chemoradiation is now increasingly frequently used in the US. The pendulum kind of swung from that to short course during COVID, now back to long course chemorads. POIV contrast, you can do IMRT, which what we do, but probably 3D may be safer. You want to position the patient prone to get their bowel out of the treatment field. You want a bladder fill as well. For your elective volume, which means your whole short course volume and the 45 gray volume, if you're doing long course, you want to cover the mesorectum. You want to cover nodes, including the obturator nodes, the mesorectal nodes, the presacral nodes, the internal iliac nodes, external iliac nodes if they are T4. And this is a case where I think you should know your 3D fields. Trials to know. And there have been a lot, but I think these are probably the main trials. So German rectal trial, this is an old study published in 2004, Sawyer trial, looked at pre-op versus post-op long course chemoradiation, showed that preoperative chemoradiation reduced the risk of local recurrence and had less toxicity. So this was a trial that really established pre-op chemoradiation as standard of care. Oprah trial, this was done at a Memorial Sloan Kettering Cancer Center. This was an organ preservation trial, showed that giving chemoradiation before chemotherapy had higher organ preservation rates. The hypothesis is that by doing so, you give a longer time to respond to the radiation. The Rapido trial, this was a trial comparing so-called standard treatment with long course chemoradiation, surgery, adjuvant chemotherapy, with a short course TNT strategy, starting with 5 times 5, short course chemotherapy, and then surgery. The study showed that the short course TNT strategy had lower rates of distant mets, but higher local recurrence. We think the lower rate of distant mets is moving the chemotherapy up front, but the higher rate of local recurrence is potentially having the short versus long course. So actually after that study, for patients who are high risk, which is what the study included, long course has been favored for these patients. You got to know the MSKCC dostarlimab trial that was published in the New England Journal of Medicine. This is obviously not a radiation study, but this was a series of patients with MSI high rectal cancers, which is about 3-5 or so % of locally advanced rectal cancers. They were treated with dostarlimab immunotherapy, and they had a 100% complete response rate. You should know the Prospect trial, which I alluded to. This was a trial for patients who were LAR candidates, not T4 tumors. They got initial FOLFOX, and for patients who had a response to chemotherapy, they had radiation omission, and it showed that there was no difference in DFS as a non-inferiority study. So that has become a standard of care. You should know the Janus trial. This is an ongoing trial comparing FOLFOX to FOLFIRINOX with organ preservation intent, asking the question, could a triplet chemotherapy increase the proportion of patients who qualify for organ preservation? Okay, other things to know. You need a baseline MRI for staging. For response assessment and surveillance for non-operative management, you need a scope, you need an MRI and a DRE. And what is the interval? Generally, every 3 to 4 months for the first 2 to 3 years. We know that most recurrences happen in the first 2 to 3 years. MSI testing for all patients. I should definitely mention that if the patient has an MSI high tumor, the standard of care is starting with immunotherapy. We know there are more young patients with early onset colorectal cancer. Fertility counseling is important, and know that colorectal cancer screening for the general populations now begins at age 45. Lastly, maybe I should include this for indications for radiation, but if you have a patient with M1 limited disease, start with chemotherapy and then consider addressing residual tumor after. Generally, we give preoperative chemoradiation with short course if possible to really limit the time off of systemic therapy. Okay, 2 more slides. All right, hepatobiliary. This was actually a tough slide to make because it's very heterogeneous, but I think these are the main points you need to know, acknowledging that HCC is very complicated, cholangio is very complicated, but I think these are the scenarios that you may be tested about. In HCC, what are indications for radiation? One, definitive radiation for localized tumor that is not amenable to surgery or other local regional therapies. Currently, that is where we stand with regards to recommending radiation. Based on studies, it is particularly a good treatment for larger tumors and those with vascular invasion, which may be a contraindication to other local therapies. It can also be used as bridging or downstage to transplant and also palliatively. I thought about what trials to know. I mean, the main one that just came out that I think is important is RTOG 1112. This is Laura Dawson's trial looking at unresectable HCC, randomizing to sorafenib with or without radiation, SBRT. Had a signal to survival benefit with the addition of SBRT, a PFS benefit. Obviously, the limitation is that the comparison arm was sorafenib. There have been many systemic trials. I think one to know is probably I Am Brave 150, comparing sorafenib to atezo-bev, showed a survival benefit to atezo-bev, which is now a standard of care for unresectable tumors. Other things to know for HCC, you should know the Child-Pugh score because that assesses risk of mortality and also be used to risk stratify with regards to safety of radiation. So what's in the Child-Pugh score? You got bilirubin, albumin, INR, ascites, and encephalopathy. You should know BCLC staging kind of broadly. Unfortunately, that staging system does not yet include radiation, but it is a good prognostic staging system, and people generally refer to patients as BCLC early stage, A, B, C, or D. You should know, you don't need to know the details, but you should know that the imaging diagnostic criteria is based on LIRADS for HCC, which can be done on MR or CT. Non-classic RILD, radiation-induced liver disease, is defined as an increase in Child-Pugh score by 2 points, and we use that measure as one of the ways to assess toxicity after radiation. You should know that standard of care systemic therapy for our unresectable HCC is atezo-bev or durva-tremi. The latter is a STRIDE regimen. You should know that liver transplant is an option for patients for HCC and intrahepatic cholangiocarcinoma. The benefit of liver transplant, obviously, is that it takes care of the tumors and the underlying liver at risk. Obviously, the downside is that their livers are limited, and it is obviously a big procedure. You need to be on immunotherapy, then you can't get immunotherapy in the future, et cetera. I don't think you need to know the details of transplant with regards to melt points, exception points, all that, but should know that that is a treatment option. Okay. I'll go to down technique at the end because it applies to both. Cholangiocarcinoma. So the tough part about cholangio is that it really refers to several disease sites, intra, extra, hilar cholangiocarcinoma, and gallbladder tumors. Many studies included several subsites, actually, just because they're not that common, but they really have different biologies and anatomies. The main indications for radiation are unresectable tumors. They usually get chemotherapy first. And then if the tumor is still there, we can consolidate with radiation, or medically inoperable patients. And then also post-op radiation, if a patient has a positive margin, really that's the main indication, or potentially extensive lymphadenopathy. The main trial to know, because there haven't really been a lot of trials in this space, is SWOG 0809. This was a trial of extrahepatic cholangiocarcinoma and gallbladder cancer, looking at post-operative chemoradiation. Again, it's not randomized, but it provides some evidence for using post-op radiation. Other thing to know, standard of care systemic therapy is GEM, CIS, and immunotherapy at this point. Also, there are many targeted agents for cholangio. So this actually is a disease site where it is worth getting NGS to look for potential targeted therapies. Technique pearls for both HCC and cholangio. IV PO contrast, and PO, you got to do some form of motion management, and like pancreas SBRT, you should consider fiducial markers. HCC dosing, there is a range. I generally give 48 gray and 3 fractions to a Child-Pugh A, 40 gray and 5 to a Child-Pugh B, 7 or 8. I don't treat above B8 and B8, so I don't treat B9 or Cs, and 8 is a plus minus, depending on really what is causing the 8 and what the patient looks like. And also that regimen of 5 fraction versus 3 fraction for unfavorable locations. 67.5 gray and 15 fractions is also reasonable. Ted Hong's a JCO paper looking at that regimen with protons. For cholangiocarcinoma, there is retrospective data suggesting that achieving an 85 gray BD threshold may be associated with better local control. Again, there are many acceptable regimens: 54 gray and 3 fractions, 67.5 gray and 15 fractions, 50.4 and 28 if conventional. Post-op, you generally want to use conventional rather than SBRT, but I do try to do SBRT when I can. Particularly to limit the liver dose for cholangio, because the fields tend to be quite large with conventional. Palliative. So radiation can be very helpful palliatively in patients with primary liver tumors or metastatic with really extensive disease that is causing pain. And Laura Dawson has a randomized trial of 8 gray times 1 showing a benefit. So the regimen would be 8 gray times 1 or 5 gray times 2, and you treat the whole liver. The main metric to know in HCC is the 700 cc liver metric, which means that you want to keep at least 700 cc of normal liver under a certain dose, depending on the number of fractions. Where did the 700 cc come from? I once asked that. It was estimated to be a third of the liver size of a small adult male. So is it like a perfect number? No, but that is the metric that we use the most. All right. Last, anal cancer. So hopefully this is sort of the most straightforward disease site, because we give definitive chemoradiation. So the indication is definitive chemoradiation for non-metastatic tumors. So really all patients who aren't M1. Most trials were for T2 and higher, but we also treat T1 tumors if they're not amenable to a sphincter-sparing excision, and that is for improved quality of life, so they don't need a colostomy. All right, technique, IV and PO contrast, bladder fill, and then there's data for IMRT in this setting. So I think everyone's really using IMRT. Dosing is from RTOG 0529. You should know the dosing. So based on that single arm study, T2 and 0, you give 50.4 gray and 28 fractions. As a high dose, you target the gross tumor, the anal canal, the low mesorectum, and then at the same time, you give 42 gray and 28 fractions to an elective volume. And then for T3 or node higher, you give 54 gray and 30 fractions to gross tumor, anal canal, low mesorectum, plus nodes more than 3 centimeters. For nodes less than 3 centimeters, you do 50.4 gray, and then the elective volume is 45 gray. So you have 3 dose volumes. You should know the chemo. It's mitomycin C on day 1 alone. If you go 12 milligrams per meter squared, or day 1 and day 29, if you go 10 milligrams per meter squared, and then 5-FU or CAPE. Some institutions use cisplatin, but unless you're at that institution, which I think is fine to say. I think the most common regimens are MMC with 5-FU or CAPE. Elective volumes, the main thing to mention is the inguinal nodes. Those are the first echelon nodes for anal cancer, but everything else is pretty similar to rectal cancer. Trials to know. Should probably know the original Nigro-Wayne State trial that established definitive chemoradiation as standard of care. After that, there were like a whole slew of studies that tried to replace chemotherapy, to see if chemotherapy was necessary, et cetera, that basically showed that still the best regimen at that point. It was the 5-FU and mitomycin C. That was basically where it starts. I don't think you need to know all those trials in detail because they didn't really change practice. You should know RTOG 0529 because that defines our treatment dose and volumes. You should know the Act 2 trial, not the details of the trial, but that was the study that established that you want to wait 6 months to allow for a complete response. You should know the Decrease trial. It's not reported yet. It has finished accrual, but this is a study looking at radiation dose escalation, actually, and chemo dose escalation for tumors less than 4 centimeters and no negative. You can mention the Plato trial that's ongoing in Europe, looking at just basically de-escalation, treatment de-escalation for low-risk tumors and escalation for high-risk tumors. Other things to know. You need a baseline PET scan. I also get a PET to assess response. You need to do HIV testing. If the patient is HIV positive, you want to make sure they're on HAART. And as long as their CD4 count is greater than 200, you treat them the same. Know that if the histology is adenocarcinoma, you treat as a rectal cancer. So everything I'm saying here is for squamous cell cancer. If it's an adenocarcinoma, you go back to the rectal paradigm. And similarly, if you have a rectal cancer, but it's a squamous cell cancer, you treat as an anal cancer. So histology defines how you treat. Vaginal dilators for women post-treatment. This is very important when talking about toxicity because these patients, women, do get vaginal shortening, stricture, and fibrosis. So you want to recommend a vaginal dilator. Then, as I mentioned with Act 2, you want to allow 6 months post-treatment for a complete response, meaning you don't want to pull the trigger for salvage APR until earlier, unless the patient is like clearly progressing. Then you want to get restaging scans. If they have local progression, you do a salvage APR. If they have distant progression, then you unfortunately got to start chemo. All right, last slide. I know we're running late on time. Just a couple pieces of advice for the boards. They don't want to fail you, honestly. You know, when I was a resident, I had attendings tell me that they would quiz them on the most esoteric cases, like an esthesioneuroblastoma with Kadish staging and like crazy stuff. I think now the cases are much more standard, and they really want to make sure that you are safe to practice. If you get to those advanced cases, it probably means you pass. So they're not looking to fail you. For every disease site, they will ask you what your workup is. So I would recommend for the first case in every disease site, you can go into a little bit more detail. And then after that, you can say, sort of, I would do a general GI workup with focus on XYZ, dependent on what you think that cancer is or what the symptoms are. And for every workup, I'm very systematic. I do history, physical, labs, imaging, biopsy, with regards to how I'm going to work up that symptom. You want to portray competence. So basically, you know, someone told me that within the first few minutes, they might decide whether or not they're leaning towards passing versus not passing you. So, you know, just portray competence. Don't pause too much. Don't say, just like be confident because you know what you're talking about. This is kind of a joke, but, you know, don't study too much. You know, your goal is to pass. Not to get the highest score ever, you know, so just study what you need to. I think you'll do great. So let me know if there's any feedback that you have. Here is my email. If you've taken the test and, you know, you have any corrections to what I mentioned, then just shoot me an email. And I hope this was helpful. And yeah, all right, bye-bye.